as I've talked with other people on the podcast, and my sister who's a physician who worked on our products, is that so much of that feeling of getting a handle on it or control or having power over you just being able to manage it, it can be so empowering, especially when you're in a pain cycle downward and there you feel like there's no hope. So this is almost gives hope to that there is potentially a solution or management if it's not going to be cured overnight, right?
Yeah. And then, just really helps them understand that it's not in their head. But to also, as I acknowledge in there, that like there will be parts of it that get in your head. One, because people keep telling you it's in your head. So you start to believe things like that. But it's that whole, mind-body connection, right? So if you're expecting something will hurt, then that expectation is in your head, but the physical problem still needs to be addressed. It's in the periphery. It's like at your pelvic floor muscles, at your vulva, in your abdomen. If you maybe have endometriosis, you need to address the physical component, and then that will allow your mind to heal. As soon as it stops expecting that every time you get touched or anytime you have penetrative intercourse, that it's going to hurt, the more occurrences you have of pain-free connection or, intimacy or penetration or whatever, then your mind will start to let go of that expectation as well.
Yeah, that central sensitization will desensitize, we hope. So let's just give us like the rundown on vaginismus.
Yeah, so vaginismus would be something more related to the muscles by themselves in the pelvic floor, or the pelvic floor muscles, I should say. So guarding response, usually in response to an expected pain. But these patients may or may not be sort of walking around always with like higher tone, like sort of overactive muscles. They might be more situational. So, another term which I think is even more accurate than just vaginismus would be like a high tone pelvic floor dysfunction, is how we'll document it, where it's just the muscles are like at a higher resting state. And usually it's, like at baseline. But then situationally on top of that, they can become reactive if they're expecting pain. And I think for them, it's, I definitely, so I teach a course also that kind of goes through like vaginismus, vestibulodynia, interstitial cystitis, or bladder pain syndrome and endo. And I kind of like progress through what like a typical presentation of each would be and like kind of the types of questions that therapists should ask to help tease out what might be going on. But the vaginismus patients will often say, one, they might have a history of unconsummated marriage. So that would be very telling of vaginismus. But some of the other things they'll say is that they feel like they don't have a hole, that they've looked and they can't see that if they have a hole. And that is kind of like so much tension that they really, they do. Every single one that said that to me, they all do. Which should give anybody hope out there that's listening to this and thinks that they don't have one. And then, maybe history of like painful tampon insertion, but that alone, not necessarily, because that could be vestibulodynia. But the painful tampon insertion, pain with first attempts at penetration. And with the vaginismus, I would say more so than like all the other kinds of pelvic pain is there's maybe more of like a cultural association sometimes. Not necessarily, not 100% of the time, but I'm just saying like in general, maybe they come from like strictly religious kind of upbringing where they were always told that sex is bad. And now that like they're married and it's okay and they waited for marriage, like they still can't kind of unwind themselves from the like you shouldn't have sex part of their story, that they can't flip the switch that now it's okay. So there might be something like cultural like that. For example, they love to say in the literature, at least the older literature, how there's likely a history of abuse, which absolutely can happen.
Yeah.
But the majority of the patients I've seen over like the more than 20-year career I've had, most patients do not have a history of abuse. Most of them do not. It is, I think, because they get so reactive and responsive, I feel it's an assumption that providers have made that they place on patients, but what they're really responding to is their expectation of pain. And that's not really a psychological issue unless you want to tell people that have back pain that are afraid to bend over and lift the box that they have a psychological issue because they're avoiding lifting the box. Why would you avoid lifting the box? You must be crazy. Like, why would you do that?
Nobody would ever say that.
Or was your back ever abused when you were a child? Like, like you wouldn't ask that for a back patient, but they just assume because it's in an intimate area. But anyways, that could be someone's history with like vaginismus, I think, more so relative to like the other diagnoses. So I think it's
almost just like hyper guarding, right?
Like yeah,
and
essentially.
Then it becomes maybe like just the anticipatory of pain, and
and so but they also do, in the ones that I see, they have that underlying high tone pelvic floor muscle presentation. So they not only have to unlearn those patterns of like fear, like the fear response that they have, but they also have to work on the tight muscles. So like they need those medical dilators to work on muscle mobility, flexibility. And those dilators at the same time also help to train them that they can have penetration without pain, right? So they see it with like the extra small dilator, which is like tampon sized. And when they can finally insert that without pain, then they know they can use tampons. And that's like such a huge barrier. That's like the first goal. And if they want to use tampons, right? But I'm like, at least with summer coming up, you could go to the pool when you have your period.
Yes.
You could use a tampon if you wanted to. At least you could, whether or not you choose to or not. And then as they go up gradually larger and larger sizes, they start to approach their goal size. If they're partnered, approach their partner's size. Then they just start to like, oh, wow, I remember when like I couldn't even put the first dilator in, and now I'm on like the fourth dilator out of this kit of 7 dilators. And this is amazing. Like I can really see how one day it will be pain-free, right?
And the empowerment, right?
Yeah, the empowerment, all of these, just all of those expectations that they could never have sex, like that they felt broken. And now they can just see the progress through working through the kit is just,
amazing.
So amazing.
I don't have this on our list, but vulvodynia, how does that differ from vestibulodynia?
Oh, that's such a great question. You said it right.
Thank you so much. I worked really hard to say that.
So vulvodynia is more like a general phrase, like that just, it means vulvar pain. So it's talking about all the vulva, but it's not very specific as to like subclassifying it to where people's pain usually are, because you're like including the labia with that, right? So like for most patients, like their labia majora with my patients don't hurt usually. Sometimes they can, and that might be more of a generalized vulvodynia. But most of our patients that we're seeing now, it's more that vestibulodynia, which is the like vulvar vestibule. So that last part, the inner side of the inner lips that are the like last external structure before the vaginal canal. So it's really just like a subtype. So to answer your question more cleanly, vestibulodynia is a subtype of vulvodynia. And hormonally mediated vestibulodynia and neuroproliferative vestibulodynia are just subtypes of like
types of vestibulodynia. Got it. So there's 2 of those types, and you can't get it. You don't know which type it is until you get your hormones tested.
Well,
or you
not
have
necessarily.
therapy.
So I think they'll test the hormones, but by the providers that I work with are usually treating it as hormonal first because that's topical medication, and because the treatment for a neuroproliferative, if desensitization techniques don't work, is surgery. So they're starting with the least invasive thing and then moving to the more invasive. But it's not like you can like even necessarily take a picture and look at it and rule out the neuroproliferative. You can tell if they have like low estrogen, low testosterone by like certain features that the vestibule has. Like, obviously if it's like really red and inflamed looking, like there's an issue there. But like paleness, if the tissue's too pale, like that also is a
interesting.
sign. Again, if it's not like nice and, pink like it should be.
Not
If
enough
it
blood
was
flow.
a Caucasian or pale person. So then that would be like an indicator. But just because you see that there might be a hormonal deficiency and maybe any labs that you test maybe are a little low in estrogen and testosterone systemically, but that also fluctuates with our hormone cycle. So hormone testing is not like super accurate. I can go at it and go by how the tissue looks and how it feels. And so they will treat it if they have those positive signs for hormonal deficiency. But under that, you don't necessarily know if there's a neuroproliferative phase.